Folks, if you do not wish to consent to recording of this session, please come off mic and say so now. Otherwise, we will move forward believing everyone is consenting. Thank you. Not hearing anyone come off mic, so great. Thank you. I'm excited to share with us that we have some members of our Unite Us team with us here today. You folks may recall that a few weeks ago we had the Point Click Care team come in and do a demo of their platform. All of the centers are on the Point Click Care platform already and using it to different degrees. We are, as I had shared in that session, we are looking at upgrading the experience for the community mental health centers so that you would have improved functionality that will hopefully make life easier over the long run and improve care coordination for people. The Unite Us team is the sort of the outer circle of our vision for the care coordination initiative. So I was in a very interesting conversation the other day with the department's new COO, Dave Waiters, and we were imagining how we draw this out, how we make a sort of a graphical image. And he shared something very helpful, that when you think of the whole person care coordination, he sees the Unite Us as the outer circle. So the outer circle of that whole person care coordination, because it's payer agnostic, it's not limited to just services that come out of some sort of sponsorship from the Department of Health and Human Services. It could include education, the justice system, a whole variety, environmental agencies. It's soup to nuts that we could be looking at helping people connect to services through. And then within the next part of that circle would be the Point Click Care, which is very much more specific to those providers that are in our healthcare system. So I thought that was helpful, and I just wanted to share that because it's sort of a challenging wrapping our heads around all this work with the different platforms. And the 10 centers, many of you, based on what we talked about last week, have either put in brand new EMRs or are doing that right now. And you know, your plate is full of technology related discussions these days, I'm sure. But we did want to bring Unite Us forward to give an overview of, a general demo of their existing platform. That's one of the things that some folks have struggled with, is that we're not building a brand new platform. They have a live platform. What we will be doing is building some customization for some of the very distinct work that the department does with our providers, like the community mental health centers. And as part of that work, the cost for the license or subscription, if you will, to the Unite Us product will be covered with a state contract. The state contract will pay for a significant customization. And at the provider end, it does include provisions to work on interoperability to the greatest degree that we can, and obviously within the financial resources we have. So there is a lot to learn still, and we are just really beginning the discovery stages on a lot of fronts. With that being said, I'm going to turn it over to Ashley Ellert from our Unite Us team. And we could do a whole round of introductions, but we actually have a lot of people, and this is only an hour. So Ashley, if you want to introduce who you've brought with us today, and then just take us into the demo, and we can feel free to put your questions, folks, into the chat. And just remember, this is just their existing product. It's not necessarily how we would sort of customize some things as we move forward. So Ashley, you're on.
Awesome. Thank you. Good morning, everyone. My name is Ashley Ehlert. I am Senior Manager of Enterprise Services at Unite Us. My role in this project, I'm a part of our implementation team. So I come alone today, but there are tons of people beside me, a part of this project, including other implementation team members, customer success, technical solutions, among a number of other roles. So just hard to get them in a room on a Friday. So excited to be here. Diana, should I go ahead and get started, or was there anything else you wanted to do?
Go ahead and get started. Thank you.
All right. So I know a few of you have seen this presentation before, but hopefully, seeing it again is always a nice opportunity. What I have today for you is, as Diana was saying, a very general introduction to sort of Unite Us, our partnership with DHHS, and then most importantly, or probably most interesting at least, is a demo of our software. And so as I go through these slides and through the demo, please feel free to stop and ask questions. I'll try and tailor it and make it as relevant to your workflows as possible, but I do know we have a number of people in the room, so please feel free to come off of mute or use the chat to ask any specific questions. All right, just to sort of ensure that we're all on the same page in terms of who Unite Us is and our partnership with the state, I do have just a few background slides before I get into the demo. Unite Us is a social care referral software company. So our goal here is to connect providers our goal is to have providers connect their patients who present with health-related social needs to other social care providers in their communities. So as a company, we are over 10 years old. We celebrated our 10-year anniversary last year, and we have been very busy over the last decade. So to date, we have made over 21 million connections to care. Of these connections, we've been able to fulfill over 88% of client needs, meaning that we're not just connecting people to social care services, but we are serving them in really meaningful ways and truly getting at the help that they need. On our platform, we have over 1 million services available, and those services are spread across 44 states. So we have networks built out in 44 states, partnerships and more than that, but we are, very dedicated to continuing to build out state by state all across the country. Our goal here at Unite Us is to build a world of connected communities that are dedicated to improving the health and well-being of the individuals within them. So we take a very community-centric approach, working with our customers and community partners in each of the states that we are growing in to ensure that we have, the best people who are in the populations that we're serving and working alongside them to make sure that we are deploying our network appropriately and in a way that makes the most sense for the communities that we're coming into. So how do we achieve that goal of connecting communities? It is by working with government, healthcare, social services, and driving those connections within the communities between providers to the community partners that are providing the social care services to patients. So we have a number of different solutions at Unite Us, and today we'll be talking about what we call our core platform, which is that social care referral platform. And then to sort of bring this home for Unite Us, what does all that mean for the state of New Hampshire? We have partnered with DHHS to deploy a closed loop referral across the state of New Hampshire. So we will provide organizations and users across the state with access to the Unite Us platform. We will work with you all in the user groups that we're bringing onto the platform to build a very strong network of community partners. So ensuring that the CBOs that you most commonly work with and other providers in the community are on the platform as well to support both ends of that referral workflow. We'll help you invest in the community partnerships, strengthening the Unite Us network, and the ability to seamlessly connect patients across different providers across their communities. And then we'll work with a few organizations to build and support local care coordination centers, which will help increase the number of access points for patients and really build out ways for them to self-refer for social care services. So through our platform, Providers can send other providers social care referrals, but we do have a way for clients to submit a request and self-refer for social care services. So we'll be working on setting up those different access points for patients across New Hampshire. Additionally, Unitas will leverage our interoperability capabilities, as Diana mentioned, to streamline workflows and enhance your user experience. So we've initiated some technical discovery around here and will continue to do so to determine which of our interoperability features make the most sense for the state of New Hampshire. And we'll do all of this while leveraging, again, our decade plus of experience and best practices to really deliver a project that we hope seamlessly integrates with your existing processes and priorities. We always work with the organizations that we're onboarding to ensure that, Unitas isn't just another software, but it really integrates very nicely into your existing workflows. Are there any questions about Unitas or sort of our partnership here before I move into a demo?
Can I ask a question?
Yes.
This is Kelly Cappuccino. I'm thinking about when we sort of launched this partnership in New Hampshire a number of years ago with the IDNs, all of whom are represented here. And one of the challenges that we had was the volume of information at the front end. Like people were really happy to come on board and they selected Unite Us and people wanted to use it. But this is a dramatization. But we thought we'd be doing a referral by capturing 20 pieces of information. And it turned out we had to capture 100 pieces of information. And 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 people didn't engage after that. So I'm looking forward to the demo, and I'm interested to see if there's any efficiencies that might have been considered as we continue to move forward.
It's a great question and a concern that we do hear. People don't want to add a bunch of additional work to their teams. I wasn't here prior, so I'm not sure what the experience was then, but to sort of speak to today, the technology we have, we do have some patient matching functionality built into the platform. So, for example, if you use an EHR, we can sort of pre-populate some demographic information for clients, pull information from the EHR. We also, once a client record has been created, you don't have to duplicate it again. So we do have what we call a master person index, which basically allows you to pull a prior created record for a client. And lastly, we'll kind of talk through this a little bit here in the demo, but to send a basic referral, really all you need are client identifiers, so first name, last name, date of birth, and then the reason for the referral and who you're sending it to. So that's 5 pieces of information. I know it's never quite that simple.
No, that's a good answer.
Yeah, but we'll kind of talk through the different fields that we offer for you to fill out. And it's very situational because sometimes who you're sending to may need more information in order to confirm that the client meets eligibility criteria. Maybe they need an age or insurance information, something like that. But I'll show you that in the demo here in a few minutes.
Ashley, is it possible to ingest like a CSV of a patient caseload with all of the fields of information? Well, not all, but the ones that are identified as sort of necessary, so that they could, if we had consent, we could sort of pre-populate them as clients in the system and then initiate the referrals once we needed them to?
Yeah, we do offer roster ingestion. It would require some technical discovery from our technical solutions team just to make sure that systems are compatible and formats and all of that.
Right.
But it is something that we do.
Okay. And so, Kelly, that might help when we're thinking about the future possibilities. Nikki?
Ashley, do I remember you saying that there is also logic built in? So if you fill out certain pieces of information in the profile that programs they're eligible for are customized based on what they would qualify for. Do I remember that correctly?
Yeah, so we do have some demographic filters that would help dwindle down the number of services. For example, if you select that, a client's gender is female or that they're over 18, that could impact some of the referral options that you see. Any other questions before I move on to the demo? These are great so far. Okay. So now for the fun part. All right. So a couple of caveats before I begin. You will hear me use the term patient and client interchangeably. At Unitas, they're synonymous. We know that different organizations call the people that they're sending referrals for different things. And so just to clarify who I mean when I say client or patient, and then when I say end user or provider, I'm referring to the person from your organization who's in the platform sending the referral. And then lastly, this is our demo environment. All of this is fake data. So it's very similar look and feel to our production environment, but no PII or PHI concerns. All right, so today I'm logging in as Barry Crump, a provider at New Hampshire Workforce Solutions. And once I've logged in, I'm taken to my dashboard. This is the landing page in the Unitas platform. Does sort of look like an email inbox. I've heard people call it that. But you can see there are a number of different places that we can navigate to inside the platform here. So over on this blue sidebar on the left, up at the top, we have our inbound referrals. So these are the referrals. If you're set up to receive referrals, these are the ones that have come into your organization from other providers or community partners. Once you've accepted that inbound referral, it pops down here into your internal cases section. This is where you can manage those cases, document any service provision for that client, and then ultimately, ideally, be able to close it out with a resolution. Below that, you have your outbound referrals. So all organizations will have access to send out referrals to other community partners. These outbound referrals, once they've been accepted, will turn into your external cases. So sort of same process as the internal ones or inbound ones. Once you've sent out a referral to a community partner, they've accepted it, you're able to follow along on that case, track the status of that case, understand what's been happening to your client and making sure that they're getting the resolution that you were hoping for them. There are some viewing limitations. So if you are sending a sensitive referral or if you're sending a referral to a sensitive organization, so these could be things like legal services, DV or IV, SUD, different service types that we classify as sensitive here at Unitas. You may have some viewing restrictions, just an extra layer of security that Unitas adds, but in general, you're able to track the outcomes of the referrals that you're sending out. And then this last field right here. Oh, was there a question? All right.
I think there, oh, sorry, Ashley. I think there was something in the chat from Diana.
Okay.
Well, yeah, no, somebody had asked a question, but I had answered it, and we can get back to that after if you want.
Okay, awesome. Thank you. Sorry, when I'm sharing my screen, I don't have great access to the chat, so just let me know if I need to address anything.
Yeah, we will. It was just about the roster ingestion, so that's why I said we can get back to it.
Sounds good. This last field right here, assistance requests. So this won't be viewable to everyone, only people who have an assistance request form configured. This really goes back to those coordination centers that we were talking about. So this is the way for the client to self-refer for social care services. If they were to submit an assistance request form, it would show up right here and I could take action on it just like an inbound referral. So to show you what it looks like to take action on an inbound referral, I'm going to go to my inbound referrals basket. I'm going to open up one of these new referrals and I'm going to get all the information that I need on it, read what this referral is being sent to me for, who it's for, some more information about the services that this client is seeking. And then I'm going to go ahead and I'm going to take action on it and I'm going to accept this referral. At the point of accepting the referral, I'll need to assign them to a program at my organization and then a primary worker. So we want to make sure that we have someone from our team who is responsible for making sure that this client receives care. So once I've assigned it to a program and a worker, I'll hit save and you'll see it does pop down into that internal cases section. From in here, I can take action on the case. So you can add forms if you wanted to complete a screening form. Maybe you wanted to do some additional social care screening. I could do that. I can add notes to the case. So maybe I called this person on the phone, scheduled an appointment with them. I could document that. When they come in for the appointment, I can document the services that I provided to them. We also just have a general note. So if you just want to sort of track some information that you shared with the client or some activity that's happened, you can do all that inside the case itself. Once I was able to provide services to this client, I can go ahead and close out the case. So ideally, I'd be able to mark it as resolved, write the outcome, add a note, and then go ahead and close the case. All right, I'm going to talk through the different tabs up at the top now. So this is my dashboard. Again, this is where I'm managing those referrals and those cases. In my clients tab, this is where I can see a list of all of the clients that have been or are currently being served by my organization. So if I were to open up one of these clients, I'm taken to what's called their face sheet. We have this nice overview tab where I can quickly see messages, notes, relationships. So who is a part of this client's care team, who their family members are. I also have an in-depth profile where I can get more detailed contact information, demographic information. I can see a copy of their informed consent, military affiliation, just additional details like that. And then from inside the face sheet, I also have a full case history and a full referral history for this client. So I'm able to sort of see historical social care data. Next to the Clients tab, I have an Exports feature. So depending on what role you have in the platform, you may see this Exports feature where you can export platform data for your organization. So if I was a team lead here at Northeast Workforce Solutions and I wanted to pull case history for the last 6 months, maybe for reporting or something like that, I could go ahead and specify the export type and the date range, hit save, and then it would generate a CSV file for me with that data. And then the last tab right here is the My Network tab. So this is one of my favorite features in the platform. I'm a very visual person. I love this map view. This shows you all of the different programs in your area that are providing social care services. So as you can see, a ton of different filters up here at the top. You can filter by service type. You can indicate which of your services are your favorite program. So if there's a community partner that you frequently work with, you can, indicate that they're one of your favorites. More filters over here. So again, if you want to filter by demographic data, age, gender, certain populations, if you need programs that serve veterans, homeless, justice involved, you can filter by all of that over here. And then if I wanted to learn more about any of these programs that I'm seeing over here, if I click on them, it opens up this sidebar where I can get more information about the program, any eligibility criteria that they require for clients. So this is talking about, Medicare enrollment. It talks about accessibility, specializations, if they offer languages outside of English. So if you need a program that can support a Spanish-speaking individual, you can specify and learn all of that in this sidebar over here and through the filters. All right, so now I'm going to show you what it looks like to send a referral. So I'm going to type in first name, last name, and date of birth. So this is where you are going to. So once you put in that information, our system is going to automatically search for a duplicate. And as long as we didn't find a duplicate client, I'm able to proceed with creating a new client. So I'm gonna do a new client today so that we can see the consent process. So here's where you can add in additional information. Again, I know that we see these red asterisks. To my knowledge, they are not required. You can fast forward through all of this. You just need to make sure that, again, you have a patient identifier and a reason for the referral and who you're sending it to. We do, of course, recommend adding as much information as possible just because it makes their profile more complete. As they receive subsequent care, they have to answer less questions. I think it's in the best interest of our patients to add in as much information as they're comfortable sharing. Contact information, so how they like to be contacted, the different ways that we can contact them, making sure that people can get in touch. An address, so the address will directly impact the referral radius. So we can change the radius, we can remove the radius, but our system does sort of pre-populate the closest programs to the client to make sure that we are sending them to places that are accessible to them. Contact preferences. So if your client, needs to be contacted in the afternoon, or if they're okay having, their daughter answer for them or something like that, we can indicate all of that information here. Military affiliation. So if they're a military member, veteran, family member. Once I've input information about my client, I am taken to this New Hampshire specific consent form. And so this asks the two questions that we need to ask all clients being served by the Unitas platform in the state of New Hampshire that have to do with sharing data back to the state. So if you were to select yes here, if your client was consenting positively to both of these questions, then we would be able to share their information back with the state. If they were to select no, then we would segment that data out of the data deliverables that we provide back to the state. So it doesn't impact whether or not you can use the platform to send a referral for them. It does not impact providing them services. It just dictates who we can share their data with. So today I'm going to opt in. I'm okay with sharing my data back to the state for reporting purposes. And once I've selected that one, I'm taken to the Unitas consent. And so here is where I can indicate that I'm okay having my information shared using the Unitas platform. So if I were to select no to this one, my service care provider is no longer able to send a referral for me using the Unitas platform. You can still provide services. It would just have to happen, and those connections would have to be made outside of the Unitas platform. We collect consent, or we can collect consent on our web app in 6 different ways. Again, we do have an integrated version of our platform. On that one, there are 4 different ways, but the most common one, and the way that is supported by both versions of the platform, is this on-screen consent by attestation, which I, as the provider, if I were to select this one, would be taken to a script that I could read to my client, a series of questions that I would need to ask them to confirm their eligibility or their consent. And then I, as the provider, could sign on their behalf. So it's a nice way, the client isn't responsible for signing anything. Sometimes signing on screen is really hard. Just kind of helps you surpass that. All right, so I've added my client. So now what I'm going to do is I'm going to send a referral for Harry. So I'm taken to the referral workflow. And I need to indicate the service that I'm sending this referral for. So today I'm going to send that referral for emergency food. I'm going to open back up that map view that we saw earlier, and I'm going to select the programs that I want to send that referral to. You can send it to multiple programs at once. That's completely okay in our system. You can also send multiple referrals at once. So we know oftentimes health-related social needs are co-occurring. So if your client needs emergency food and emergency housing, or if they need help picking up a prescription as well, you can add in all of those referrals at the same time and send them out in one go. Add in a description about the services that my client is requesting. A few supplemental questions, so a few standard client supplemental questions, and then service type specific questions. So I selected a food service type, so I'm going to be asked for food assistance specific questions. These have to do with, eligibility for government programs, or more information about the client's household, how many people in their household need food assistance, income questions. Basically, just additional questions that would help food providers to determine eligibility into their programs. Once I've input all that information, I can just go through it and make sure everything looks correct. And then if it is, I can go ahead and send out that referral, and then I see it up here at the top. Any questions?
Thank you, Ashley. Great job. So we'll open up the floor. So as you guys are, as folks are thinking about this, some of the customized development that we're working on is for the rapid response mobile crisis. And Unitas was with the QI directors in a session yesterday with Brian Harvey and did a similar demo. One of the things that we want to make sure people are really thinking about is that we will have work group based collaboration for the customization that we're looking at. So for instance, there is a care traffic control work group that is co-led by New Hampshire Hospital and the New Hampshire Hospital Association. And they have been the team that has been working together for the IEA ED boarding crisis resolution. They have, the internal resources have started to meet with the Unitas team to develop the workflows. So Nikki Gothier had met with them for quite some time to identify what their workflows were, and now we've brought everybody together. And in that work group, we've got representation from the different parts of the New Hampshire Hospital, and they will be convening. I don't know, have you guys started convening with the external partners also yet in that work group? Ashley and Nikki?
Not yet.
Not yet. So they're still orienting the New Hampshire Hospital team on all of the possibilities. And then the CMHCs, the DRFs, and the hospitals are in that larger work group. So that work will go through that way with weekly to bi-weekly meetings to pursue that. Also, for mobile crisis, we're doing that, and we will be doing that for the supportive housing service. We will be doing it for work with the doorways, the ADRCs, the service link sites, and MCOs. So we will be having a series of sessions over the summer with the MCOs for how we can leverage this platform and the Point Click Care platform. Part of what we're striving for is to get to this place where the involved parties, whether they're in the north part of the state, the southern part of the state, whether they're a CMHC or a DRF, that, you know, everybody's sort of on the same page with how we will do a particular function through the platforms. And that will create some relief in the workplace, both from the clinical side and from the administrative burden side. So one of the things I shared yesterday is that the department is looking at our contracts with the managed care organizations, with the providers, where we do have contracts, so that we could say, if we can see this activity happening in the closed loop referral, you can generate your reports from there, or we can generate data from there, and we won't need to pursue as many customized provider-specific developed reports. So one of the things that we're talking about is the current ACT and SC waitlist reporting. You know, I know that that is very time-consuming from the centers and the managed care organizations, and that there's a workforce crisis. Where is the significant additional value for all of that extra work that we were doing? If we move some of that work into connecting people to services, if we start thinking of connecting people to services as a referral, then if we do it in these platforms, they will automatically come with timestamps, automatically come with the ability to generate reports, to manage those referrals for services and how long people are waiting. We're similarly talking about this for some of the measures associated with the certified behavioral health, certified community behavioral health clinics, the CCBHCs. And it may be useful in some of our directed payment work as well. So we are trying to look at this as pursuing whole person care coordination, but also pursuing efficiencies within our system, so that we are not all constantly chasing the latest, the greatest, the newest niche information technology platform and paying a ton of money for all of that all the time. If we can take some basic standards of interoperability and gain some efficiency at the same time, we think that that is a more promising approach for people to embrace. Jay, I think I saw you raised your hand.
I did. So when we looked at this through the IDN, one of the largest barriers was that it would require staff to document in 2 systems, which is going to double the administrative burden for the actual providers of these services. Can you talk to me about how we would avoid that, so that the information is in our electronic health records, which allows us to then process the billing and meet all of the requirements for documentation for case management services if we're entering it into the Unitas platform? How can we not have to duplicate?
Yeah,
So,
can you,
go ahead, Ashley? Yeah.
could you tell me more about the other system? You said it's an electronic health record?
Right, so we're in the process of implementing InSync, but it's any electronic health record, so this would apply to all of us here. That was the barrier when we looked at Unitas as part of the Region 6 IDN.
Okay, yeah, this really goes back to what Diana was saying. So we'll explore interoperability opportunities. If we are able to integrate with your EHR, we do standard integrations with a number of them. It will reduce the amount of information that you have to put into the Unitas platform. The Unitas platform would simply be used to make that referral, which, you know, of course, can't be done in the EHR itself. So you'd use Unitas to make the referral, and that way you wouldn't have to do duplicate entry for client information and things like that.
But you
So
would
we'll
have to do
explore-
duplicate entry for the actual referral and provision of care and supports.
Do you document that information in your EHR right now?
Mhm.
Okay. We can talk through, when we get into individual user groups, we'll talk through very specific use cases like that. We do have a few solutions that might be able to sort of reduce, the amount of duplication you have to do, until I know more about the EHR that you use and the compatibility with our integrations, I don't want to say too much. So I think there's a lot of opportunity. I think Unitas has really worked hard over the last couple of years to develop a really seamless integration with a number of EHRs, so we can kind of talk through what that might look like for yours.
Thank you.
So
So
can I
in
add
the
to that?
procurement-
Diana,
sure,
can I
Pat.
add to that? I think
Yep.
it would be really important for us then to collect the names of all of our electronic health records and submit them so that we can understand either timelines for the potential for interoperability. Because the other side of this is that it's great to hear that Unitas has worked on this. You know, our experience here with the IDN has been similar, but I'll only speak for ours, which is NetSmart and Avatar. There's often costs on our side that are related to anything that we have to alter. There hasn't been anything that we haven't had to pay for. And so, you know, again, depending on the cost to that, might be a challenge for us. And especially now in our positions financially. And I feel like that is going to be a big thing that we're going to have to consider. Any burden, more burden that goes toward our staff for any period of time is really, we can't risk sort of losing more people over multiple systems and things that they feel really interfere with what they want to be doing, which is being with patients. And we'll also have to talk through certain areas that I think how we do this is going to be a challenge if there's a period of time that we have to use multiple systems. Rapid response, how we do that, who does this while they're trying to respond to a call, when a call might get backed up and so forth, are things we'll have to work through. But I think we really, any speed we can put on thinking about this interoperability issue is key.
So Patricia, I was the one doing the little clapping hands, because if folks can send in their exactly what you just described for their EHRs, the names or any specs that you can, I'm sure that it would be a welcome thing right now for the Unitas team to see.
Okay.
And
to you, Diana, do you want that to go to you or to the Unitas folks?
if you want to send it to me, and to, actually, you know what, we've set up a mailbox, DHHS. Nikki, can you put the link in for the DHHS care coordination mailbox? Because that will be very specific to this effort, and that way you don't have to think of who the person is, just think care coordination, it should come through. We can feed all of that to Ashley's team. And Ashley, if you want to put your email address, whoever you want to receive that in the chat, then the CMHC staff will see it as well. You can CC them too. Ashley, can you give folks an idea of when, what the process sort of looks like when it's, you know that you have a provider that you want to onboard and you've got to start that whole IT discovery related process?
Yeah, it really depends. I know that's not a great answer, but we have some implementations that take as quickly as 8 weeks. Typically, if you have an integration involved, it's going to be longer. So that might be more between 12 and 16 weeks, depending on the complexity of the integration. And basically, what that looks like is a series of phases that includes discovery and planning, where we do that technical discovery. We do discovery around your team's workflows. Once we complete discovery and planning, we move into engagement. So making sure that everyone from your team who will be using the Unitas platform has a chance to see a demo, gets to ask their own questions. That also informs the workflow conversations that we have. Once we complete engagement, we move into onboarding, where we train your end users, we configure your organization onto the Unitas platform, and then we move into our go live phase, which is when you begin to receive access to the Unitas platform.
Kelly?
Yeah, I guess along the line of what people are already thinking more broadly, downstream efficiencies have upstream impact on our staffing resources. So in order to get to the downstream efficiencies, we have to make adjustments at the other end because there is time that's required to utilize the platform. And that in alignment with all the other things that are going on, but not the least of which is CCBHC and being able to anticipate costs that may come to us, and not just cost. Patricia's point is really good in terms of we have to pay for modifications, but also cost for staffing, because if I have 10 staff now who serve, I'll just make something up, 500 people, those 10 staff now may, to get me to downstream efficiencies, serve 400 people. And now I need more staff, but I have to be able to anticipate that so that I can build a budget for my other project, CCBHC, that addresses some of this. And so it would be helpful to know any information that you can share from existing partners who are already all the way downstream and can share what that looked like for them. And if they're in CCBHC states, that would be even better.
Yeah, absolutely. If I'm following the question correctly, or sort of the feedback correctly, we'll definitely bring some use cases of similar organizations and try to apply those best practices. We know that, when you're adding a new software or a new process, there's a ton of change management involved, and sometimes learning and hearing from others' successful implementations is a really nice way to just get buy-in and sort of see the potential benefits that could come from adopting the platform. So I think that's really valuable feedback and will help us sort of tailor the messaging to your teams and make sure that we're delivering the opportunity to them in the right way.
There's a question in the chat, and then I think Chris has his or her hand raised. I couldn't see which one. I just saw the name pop up. So the question in the chat would like to see information in the other direction as well. What is their ability to use a standard API that is not vendor integration specific? So that is about the UU APIs. So I'll pause there.
Yeah, we unfortunately don't have the right people on today to talk APIs. I'm not a technical team member. I know that we have a number of standard APIs as well as a roadmap to add more, but that's sort of the extent of my knowledge today. But we can make sure that if that continues to be an outstanding question, we can have the right people from the Unitas team.
Would all the centers be interested if we could do it for, I don't know if next Friday is the best Friday, but if we could take one of these sessions and have it be specific with your IT teams.
Well, the reason the question is being asked, right, is there's a huge variety across the state with different systems. And you're asking us to also get other participants on board that are going to have many of the same kind of challenges that we have. And if there's a big long line in queue of people trying to get their special system integrations done, basically the number of participants that's going to be engaged out of the gate is going to be small. And when it's small, then we have to do one way for this small group, and then all sorts of different ways depending on, the level of implementation of other groups. So that's the reason the question's being posed.
Right. So would we like a session though with your IT resources at a meeting specifically with the UU IT resources there as well?
I personally feel that would be helpful.
Okay, Diana, I'll take that back to our technical team.
Okay, great. So Chris had a question. I don't know which Chris, but
this is Chris Mumford from Riverbend. Thanks. I'm sure I must have missed something, but I just want to get clarification. is this a requirement for the centers to join up? And if so, what's the timeline for implementation that you envision?
So it depends on which workflow, but I think that you already have in your contracts a requirement to use the department selected solutions. Is that
I believe so, yeah.
okay? So the timeline will be different depending on which functionality it is. So for instance, right now in the mobile crisis space, there's technology that supports most of the needs of that overall overarching program right now. There was one specific gap that we did not have any sort of remotely convenient place to or solution to handle. So we're working on that particular piece right now. And then the open beds subcontract should move under Unite Us for the second half of this year. And we will be working on exploring the Unite Us functionality for replacement of the open bed solution, but that would be for likely for 2025. So we're really taking a very calibrated approach about which things to try to move forward and when to move forward. And we're looking at places that are at functions that are already very time consuming. So care traffic control is a perfect example, right? Because we had the centers. Maybe you knew if you had a client in the ED, maybe you didn't know. Maybe you have that contract with that hospital to do those assessments. Maybe you don't. Where your client was landing, if they were going into a designated receiving facility or where they were on the queue. For years that's been handled with telephone calls, with email, mass emails, fax machines, etc. That is going to be transforming into a live platform type version with customized dashboards. Fax machines should be able to go away with few exceptions. So that's just sort of how we're leaning into it. Chris, does that make sense?
Partially, yeah. I mean, I'm looking for a more specific timeline of when you're going to engage each center and in what fashion, but helps a little bit. Thanks.
Well, I think that we can start working on building out the calendar. We didn't want to start building out a calendar on getting all 10 CMHCs before having some orientation for the centers, right? I mean, at least a little bit of a demo, and then also wanting to be informed by the timeline of the work groups that are involved with those very distinct processes like mobile crisis and connecting with the doorways and the care traffic control, et cetera. So if we can share that exchange of information on the IT side, I think that the Unitas team would be glad to get a green light to start pursuing the CMHC specific level discussions on how to onboard.
And will it be all 10 of us at the same time?
My understanding is you folks all are at sort of different places with your EHRs right now, and you have some capacity issues. So I think, Chris, it would be foolish of me to say it's all at one time or not. We do need to be cognizant of resource challenges across the entire system. Patricia, were you going to say something? No, okay. We have a few more minutes. Thoughts, questions? So I'm hearing that the centers are ready or eager to at least start learning more on the IT front and the CMHC specific. Do you want us to provide your CIO contact information to the Unitas team, or do you want it to go through the EDs? How do you folks want to start those conversations?
Chris Kozak is the CEO liaison to the CIO group, so that might be a good single point person. And Patrick Ullman, please correct me if I'm wrong on that, but I think he's the current.
I think that's a great approach, Jay. Yeah, I'd say that you've got the probably simplest one there. Yep.
It's the CIO committee? Is that what you
There's
call it?
a CIO group that meets regularly, and Chris Kozak is the oversight ED for that group.
Great.
He'll love that I added some work for him.
As long
I
as he
think
knows
that's
it was
great.
you and not me. Yes.
I'll email him. I'll give him a heads up.
Carolyn, thoughts? Do you have any thoughts that you want to bring into the room? Carolyn Lewis, I saw your face come up and I thought, well, she's been quiet. I'm going to see if she has anything to say today. Oh, you're on mute.
Thanks. I said I don't have anything necessarily to say. This is kind of the first time I had a chance to really walk through this. And you know, my question, I guess, would bounce it back to the centers to make sure that this is working for them.
I
I
think
guess
that's a
we will
really good
find out.
question that we're not sure we can answer right now. I mean, for me,
Right.
it's at Northern, I can't answer that. You know, it depends on whether or not we'll be financially supported in our contracts to implement this. And the staffing shortage is pretty critical, and adding one more thing could be a tipping point. I'm not going to pretend that it wouldn't be.
That's why
That's
we're
fair.
really hoping that if we focus on the pain points that are currently in the system, you know, those processes that involve a lot of partners and take a long time to work out because everyone's playing phone tag or sending fax machines, that will help start a path forward that is a little bit more practical.
I agree with you 100%. Sometimes I think we're doing so many different things and we're spread in so many different directions that although I agree with you, the end game concept is fantastic. The getting there bandwidth in the moment for the centers might be really tricky.
Mm-hmm.
So I agree
Right.
with you. I think it's a great concept. I think the plot, you know, eventually not having to do all of those different pieces would be great. But I think if you plan this, it should be a long rollout to get us up and running. New EMRs, no staff, potential trouble with integration. I mean, those are just some of my concerns. But
Right.
you know, we'll do
I
what we have to
definitely,
do.
I definitely hear you on the new EMR part. And I was glad to hear the question come up about duplicative work, because it sounds like there will be some on the front end, but maybe it will help reduce it on the back end. But getting there is going to be a challenge, of
If
course.
integration is successful, I think it will reduce on the back end. If it's not, if it's tricky and it's not cohesive, then it won't.
Right. And one of the things that I know was a challenge before, I know we're at time. So Ashley, if you need to drop, I understand. But one of the things that I know last time we tried this under the IDN is that we had really just taken that regional approach and encouraged collaboration within the region of how you would do it. But healthcare has changed a lot in New Hampshire, and people, you're reaching out of regions, out of boundaries. If you're looking at whole person needs, it's not something that is just going to be tailored at the community level. There'll be some community engagement, so we'll have that two separate tracks like we did before. But what we really want to lean in on with the actual centers, that sort of key partners, is those key workflows that are just so critical, so that you don't have to develop those relationships from one region to the next region to the next region, because you might be dealing with the same people depending on which provider is providing which service and which boundary they're in. So we're hoping that will also make it a little bit more successful. So anyways, thank you all for your time again. I hope you have a wonderful weekend, and that I will be on camera next week. Thanks. Bye.
Bye.